This is our today's agenda. As you know that we already had a inland discussion when we had a physical meeting, and we had tried to put everything into a concise algorithm format. And again, we had tried to get in touch base with you. So here and there, few points which have come up. We even tried to include those things. So our today's agenda, as sir has already mentioned, we just want that it needs to be aligned by everyone, and then those so that we can finalize this algorithm. Again, it's a privilege to have Dr. Gopinath sir to chair the session, as everyone know each other, so I won't be taking much more time on this. And we are having the same advisory board member who were there in our initial meeting, and today we will be just just finalizing the pointers which we have got. Okay, with this, sir, I will just hand it over to you. Sir, you can share your slides.
Yes.
Yes, sir, we can see. Now
Yeah.
just need to go to the presentation mode.
Yeah. We discussed in detail. All the members have put in all the points. We have just divided into 3 groups. The first group confined to this recombinant FSH-LH combination. The second group combined it with the recombinant FSH with recombinant FSH. The third group just discussed about recombinant FSH combination with HMG. So we have discussed various pointers. As Kasi was mentioning it, we have had a long discussions, but it was very nice of the team to have put it up in the form of a small algorithms, which we will be discussing it now. And in case anytime when you have any query, any change, please let me know. The group 1, we had recombinant FSH and recombinant LH 2:1, that is the pergovirus. And we had an excellent panel with Dr. Kasi Selapan, Vandana Hegde, and Diganta. So here we thought that we had our discussions based on 3 different parameters. The parameter 1 was on the hypogonadotrophic hypogonadism. So here we said preferred protocol is no antagonist and agonist. So it will be on a random start. The basic investigations we will do AFC, AMH, FSH, LH, and E2 only in cases if there is a large follicular size was seen. And then stimulation will be started with recombinant FSH and LH combination. Starting dose may be between 150 to 225 international units. The duration maybe it will run for about 9 to 11 days based on the follicular growth. When we get more than 3 follicles, 17, 19, then we will go in for trigger. So in the trigger, we thought we will go in for an HCG trigger. At that particular time, the investigations E2 only in cases of very large size, or P4 when they were decided to make a fresh or a frozen transfer. Preferably when there is a fresh transfer, we thought we'll go in for a P4. And then optimal OPU timing will be 36 hours post-trigger. So the ET strategy will be the fresh ET if it is between 0 to 15 oocytes retrieved, and serum E2 level of less than 2,500 picogram per ml, or serum progesterone is less than 1 nanogram per ml. Otherwise, we will go in for a freeze-all strategy, and day 3 or a day 5, based on the reference, they will take it. There is no necessity for pooling in this particular group. And then in PGT and ERA, only when indicated and on a standard recommended indications, not as a routine. This is what we did it on hypogonadotrophic. Now, moving on to that same thing on the suboptimal responders, that is LH polymorphism in the previous failures, where we thought we will the preferred protocol, mostly antagonist or progesterone primed ovarian stimulation. The basic investigations remain the same. E2 is only when the large follicle size is there. Pre-treatment, if appropriate, antioxidant coenzyme Q for about 6 to 8 weeks, 300 milligram BD, or luteal E2 for follicle synchronization. Then we start the stimulation on day 2. It will be 225 to 300 international unit recommended starting dose based on the BMI. If the BMI is more than 25, we will start with 300. BMI of less than 25, we will start with 225. Maximum is only about 300. We will give about 8 to 12 days based on the follicular development. The dose titration, if we want to do it, we'll be doing it somewhere between 37.5 to 75. When the follicles, again, maximum 3 follicles between 17 and 19, we'll go for a dual trigger, a double trigger. HCG is compulsory because it helps in the final maturation, and only HCG for agonist protocol when we have not used antagonist there. opioid timing is about 36 hours post-trigger. The monitoring E2, P4, LH, like how we have just seen it in the previous thing, E2 and P4. LH on day 5 and day 6 of the stimulation, if it is very high, we will consider suppressing with antagonist. If it is very low, we will increase the LH supplementation or adjust the dose accordingly. So after OPU, ET strategy, frozen ET is preferred. Fresh embryo transfer may be considered if favorable conditions are met. ET on day 3 or day 5 based on the preferences there. If it is less than 4 oocytes, pooling is advisable. And PGT and ERA only when indicated, only in standard recommended indications there. Supposing if it is going in for a subsequent cycles, probably we will consider an agonist short protocol, lifestyle modification. We will check the trigger, opioid timing, FSH-LH polymorphism testing, testosterone in the pre-treatment, and growth hormone additions alternatively based on their preferences there between 4 and 8 units there. The last one on the first group will be on advanced maternal age and poor ovarian reserve. Here, again, the preferred protocol will be antagonist or progesterone-primed ovarian stimulation. The pre-treatment, again, on antioxidants or luteal phase estrogen for synchronization. Some prefer using a testosterone 75 milligram or a DHEA OD for about 30 to 90 days. Testosterone gel, when we are using it, we'll use it for about 6 weeks. And the basal investigations will be AFC, AMH, FSH, LH, E2 only when there is a large cyst. And on day 2, the stimulation, we can start with about 150 to 225 IU is the recommended starting dose. And then the dose titration will be on 37.5 to 75. And very rarely we can go up to maximum of 375. When we reach the follicles of about 17 to 19, minimum of 3 follicles, we'll do a dual or a double trigger. Investigations will be just like the previous one, E2, P4, and LH. And then on the opioid timing will be about 34 to 36 hours post-trigger. ET strategy, frozen for PGT-A pooling, and then fresh embryo transfer may be considered if favorable conditions are met on ideally day 3 or day 5 based on the preferences there. Again, here coming to the PGT and ERA, only when it is indicated, only standard recommendations are there. Pooling, if there is less number of oocytes, we can go in for pooling. On group 2, it will be a recombinant FSH plus recombinant FSH and LH combination. The panelists were Dr. Shweta Mittal, Dr. Meenakshi Dua, and Dr. Tanya Bakshi. Here again, we discussed on advanced maternal age. Preferred protocol was antagonist in about 90%, agonist in the cohort cycle there. The basal investigation here, AFC, AMH, E2, P4, FSH, LH, in almost all the visits there, they have recommended. Pre-treatment, if appropriate, no OC pills, E2 and P4. And if the patient comes on a day 2, then we will start the stimulation straight away. If plateau in the middle of the cycle, they will prefer a recombinant LH there. So on day 2 or a day 3, depending upon the ultrasound, the adjuvants, in case if they are using it, it will be a coenzyme Q10, Q 300 to 600 per day, or testosterone gel or DHEA in the previous levels. So stimulation will be recombinant FSH 150 plus 150 of recombinant FSH and LH 2:1. That is 150 of pure FSH plus 150 of the combination from day 2. And in case if it is an expected poor response, or when the higher doses is needed, they try to increase the 300 of recombinant FSH plus static dose of 2:1, 150. So that is what they've recommended. So or 300 international units of recombinant FSH plus 150 and 150 of 2:1 combination. So this is the combination where they have just tried it. And follicle size, when it's about 17 to 18, dual trigger, primary HCG on second agonist, and then OPO timing 35 hours. ET strategy, frozen is preferred, 20 to 30% in case if there is a thing in. And if there is a pooling, it is encouraged if it is a less number of oocytes. PGT and ERA are recommended for all patients aged above 39, and ERA no major benefits. Patients discussion has to take place before we plan for it. On the second, poor ovarian reserve, it is a preferred protocol is antagonist there. The basal investigations is just like that. Pre-treatment, absolutely no OC pill. Estradiol, if the patient comes on day 2, then we will start it straight away. And in day 2 and day 3, depending upon the ultrasound, so adjuncts are used as a DHEA, testosterone gel, or a coenzyme Q10. And the stimulation protocol will be 150 recombinant FSH plus 150 of recombinant FSH and LH 2:1 from day 2. In case if the response is poor is expected, higher dose is needed, then they will go in for 300 of recombinant FSH plus 150 of combination, or 300 of recombinant plus the 2:1 combination is useful there. Then we go by the follicular size of about 15 to 16 in a poor ovarian responder here. Trigger is dual trigger. Primary is HCG, and second is the agonist there. 35 hours post trigger. And ET frozen is definitely preferred. 20 to 30% maybe a fresh transfer. Pooling is encouraged. And PGTA is just because it is an advanced age group of more than 39 years, they prefer to do a PGTA, and ERA has got no benefits on that. In case of polycystic ovarian disease, preferred protocol is antagonist. The basal investigations remain the same. The pre-treatment, if appropriate, E2 or a P4 for follicle synchronization. The stimulation is 150 of recombinant FSH plus 150 of recombinant FSH LH on day 2. And in case if there's a poor responder, or in the previous poor responders, when you need a higher dose, they start increasing only on the 300 of recombinant FSH plus the standard dose of pergovaris, they kept it there. Duration is about 12. Here, the follicular size, you can go right up to 18 to 20. Trigger, agonist trigger, and maybe a dual trigger if appropriate. And OPO timing is 35 hours post trigger. ET frozen for all cycles. Single blast on day 5. On the subsequent cycle, they will do it. Because we are expecting more, there is no place for pooling here. PGTE and ERA are prefer PGTA, but there is no ERA in case of the thing. Coming to the third group, where we have used recombinant FSH and LH combination along with HMG, the panelists were our esteemed Dr. Sachin Kulkarni and Mekhala Dwarkanath there. They've discussed on advanced maternal age. They preferred the protocol was GnRH antagonist protocol. The basal investigations more or less the same. Pre-treatment, they prefer a E2 for estrogen for follicular synchronization. Day 2 or a random start, if the follicles are synchronous, they will either pre-treated with coenzyme Q10 or DHA only if levels are different, that is deficient there, with testosterone cell if the levels are very low. The stimulation started with the recombinant FSH and LH combination of 225 for about 8 to 12 days, switching to HMG 300 in the last 2 days. So this is one trick. The third is alternatively 150 of recombinant FSH plus 150 of HMG and the last 2 to 3 days there. The dose titration initially depending on the BMI, higher dose for a higher BMI there. Trigger, it is always a dual trigger. Investigations E2, LH and P4 polymorphism testing is only optional here. OPU timing 35 hours post trigger. ET strategy is only a frozen embryo transfer is preferred, mostly on day 5. 80 to 20% ET may be on day 3. In PGT and ERA, just like that, advanced maternal age, they prefer to go in for a PGTA, but there is no ERA. Pooling is encouraged. Embryo quality improves across the cycles, which has to be kept in the bottom of the mind. Poor ovarian reserve, preferred protocol is GnRH antagonist protocol. The same the basic investigation. Pre-treatment is again on estrogen priming for the follicular synchronization. The 4th day, if started in the late luteal phase, 6 milligram per day on day 2, and random starts are if the follicles are synchronous, and adjuvants or coenzyme Q10 can be used. Stimulation started with recombinant FSH combination for about 300 units for 8 to 12 days, switching to 300 of HMD in the last 2 days. Alternatively, 150 of pergoveris plus 150 of HMG combo. The dose titration, you can go right up to about 450 of the combined dose. Duration is about 8 to 12 days maximum. Trigger will be HCG or dual trigger if appropriate. Investigation at that time, E2, LH and P4 polymorphism testing is optional. 35 hours post-trigger, we'll do the OPU. Frozen ET is mostly done on day 5. 18 to 20% ET may be on day 3 there. The PGT, again recommended for all patients above 38 to 40 years, no ERA. Pooling is encouraged. Quality of the oocytes improves across various cycles there. In the last polycystic ovarian syndrome, preferred is protocol is GnRH antagonist there, and same basal investigation. Pre-treatment is only with estrogen, and we can use adjuvants like coenzyme Q10. Stimulation will be started with recombinant FSH, then add recombinant FSH and LH along with antagonist on day 6 there. And the dose titration depending upon the response there. On average, it takes about 10 to 12 days of the follicular growth. Follicular size will be about 18 to 19.5 millimeters. At least 2 follicles will be there. Trigger will be an agonist trigger. E2 and LH and P4. P4 may not be necessary because mostly we'll be going in for a frozen. And OPU timing is 35 hours. ET strategy, it is frozen ET is preferred. Mostly on day 5. Very, very minimal cases, it might fall on day 3. PGTA is recommended for all older patients, no ERA. And there is absolutely no place for pooling because we'll have enough number of things. So to patient can be the patient selection strategy. If it happens to be in the first cycle, it can be stratified as less than 35 years and more than 35 years. If it is less than 35 years, both for poor and normal and high responders, we can start with recombinant FSH alone and then try it. And in case if it is an older age group, it's better to start with recombinant FSH and LH combination because there will be definitely a LH deficiency will be there. In the subsequent cycles, when you are taking it, again, if you look at that, if it happens to be a poor responder in the previous cycle, and if it is younger age group, it is better to start with only a FSH LH combination. If it is a high response in the previous cycle, then probably only a recombinant FSH can be taken. If the patient is older, it is more than 35 years, in a subsequent cycles, better to use recombinant FSH and LH. This is what we have just taken it. On an average, 34% will be poor, 50% will be normal, and 12% will be in high responders. So this is what we summarized from all our brains put together. And I once again thank each and everyone for putting your efforts, ideas, suggestions, and then creating this wonderful algorithm.
Yeah, thank you, sir. I think so. You have presented the entire algorithm. Now, I think so. We had already got in touch with individual all the advisory board members. We are trying to incorporate their suggestion. I know that there may be some more tweak here and there, but we are just trying to concise the broader concept at the discussion so that whenever we are going and having a discussion with the other doctors who want to use reg FSH LH into their patients, so what can be an ideal protocol so that this can be acting as a guidance document for them when they want to treat their patients so that they can have an optimal outcome. Any suggestions from any of the advisory board members? And sir, Dr. Gopinath sir, do you
Bharat,
think? Yeah.
see, each group had 3 members. At least all of them had about 30 years of experience.
Yeah.
So that means each group has got about 100 years of experience put together as formed.
Sure, sure. Yes, sir, definitely.
Sir, you shouldn't be exposing the age actually of the
I only said experience. Only experience. All of us are young.
Yeah, of course, of course. No, as I was going through, there was one slide, correct me if my memory serves me right. For a polycystic ovarian syndrome, we were discussing about 450 of FSH. Is that right?
Yeah.
No.
Sir, I will share the screen. Just a minute.
Yeah, go ahead.
I will just share the screen so that we can have a discussion.
Or maybe that's why I said maybe I got mistaken with something.
Yeah, so this slide, I think so you were referring, no?
Yeah. So you got 300 FSH along with 150 FSH LH, which means you're talking 450 there of FSH.
Yeah, they are talking. So even when we were having the discussion, we just wanted to have the opinion whether it is an appropriate or these are only limited only to a few patients, because
this is the second group, right?
Second group.
Second group people are here. They can put in the comments.
Yeah.
Actually, it was that in case patients doesn't respond to 300, then we can increase. But that is very, very rare. If they have FSH and LH receptor polymorphism, only in those cases, PCO we will have to increase the dose. Otherwise, hardly we get to increase in PCO. 300 itself is too much.
Correct.
For them.
Yeah. I think I'd agree with Meenakshi. I think what we had discussed with PCO was a much lower dose.
Yeah.
And again, the titration, I think we'd also said of about 37.5 to 75. Now, there are that subgroup of PCO which doesn't respond, where you've got so many follicles and you've just got 1 or 2 growing. So I think this doesn't come out clearly.
Correct. So if they can specify it there, only for polymorphism cases, then it will be better off, especially when they are talking to someone else. They shouldn't get carried away with the dosing and end up with an OHSS.
Correct. And even the top one, actually, where it says 150 plus 150 of the pergoveris, that is a higher dose again.
Yes.
And that, again, we had said would be potentially 75. So I think this needs to be rejigged with the PCO.
Correct.
The second group PCO, Bharat, so the dosage has to come down.
Yeah.
If you
Yeah.
could
Yes,
do,
I think.
if you can correct that slide,
Yeah.
send it to the second group and get it concerned, then
Yes.
it will be there.
Sure, sure, definitely, sir. Because this was my concern when I think so. We had gone through the recording and this slide was prepared, but there was some confusion because this was set for a rare kind of a difficult to treat group, and those got captured. And that was the precise reason. Even I wanted to have the expert opinion on particularly this slide, because normally we see have seen around 150 we start on an average, and then based on the response we might either decrease or increase, or even we be starting with a lower dose also. So definitely we will rework on this slide. So the starting dose currently, if I am understanding correctly, is can will be around 150 IU as a starting
Bharat,
dose.
it can
And
be 150 or 225. Even again, it'll match on the BMI, na? So I
okay,
think we
And
have to
AMH
put
also.
everything into perspective: AFC, AMH, age, BMI. So
okay,
PCO doesn't have to be only. Let's say she can be 32 or she can be 38. So
okay,
it will vary. Also, if her BMI is 24 versus BMI is 34, it will vary.
In fact,
okay.
in PCOS, any dose more than 300, I am very scared actually.
Yes, correct.
Yeah,
Yeah, I
So
think we should not put it over here as 450.
No.
And
Yes.
also, see, maximum we may see probably in suboptimal responder, which is again covered. Even in a PCO, if there is suboptimal response, then only we can think of all this, right? So I think we can
Correct.
avoid that over here.
okay. So we will remove this 300 dosing part, and we will right now incorporate 150 IU for a lower BMI and 225 IU based on a higher BMI, and then we will just reshare this slide with the group so as to just validate this thing before we just
Sorry,
finalize this slide.
No, up to
there
a
is-
maximum dose of 300, we can keep it, I think. See,
Yeah.
maximum dose of 300, which is left to the clinicians, you know.
Yeah.
And I
mean,
think we
think
should add in at every point assess response. I think
Correct.
that is something. And again, with the trigger,
Hmm.
so agonist trigger, if excessive response, we should say preferred.
Correct.
And dual in some, because most will be doing a agonist, and that is what we want to even share with everybody. Dual, again, in PCOS, we are looking at some specific groups. Otherwise,
Okay.
mostly all of us will prefer just to give an agonist. So rather than saying if excessive response, we say agonist is preferred and dual if indicated. So rather than just stating excessive response, because it seems as if we are saying that maybe first try a dual and then put a agonist.
Sure,
actually
madam.
PCO will vary on AMH levels also.
Yeah,
PCO can be
AFC,
4
AMH,
AMH
everything.
and 20 AMH. And I think that should also come. That if you have 4 to 8, you can give 225, but above 8, you should give 150. And based on the response, you can increase. Something like that with age and BMI, keeping all three together.
I personally feel that in PCO, we should just write a dictum that they are hyper responders. They
Yeah.
need a lower starting dose, which normally should be 150. And in only special cases, because we never start with 300 in a PCO girl. And we are
Absolutely.
talking about a treatment naive or a first time IVF cycle, and only 225 in special cases. I think the dual trigger doesn't feature in PCO at all. There is either an
Yes.
agonist trigger, and
Yes.
if a PCO girl shows like a 1500 E2 with 8 follicles, then it can be an HCG trigger. So a dual trigger doesn't feature in PCO.
I think
Dual
somewhere
trigger
the slides
actually
have got mixed
features
up.
only in poor responders. So I think our message needs to be clear.
Clear.
That here they are hyper responder. The usual starting dose is 150. I don't think we want to give lower. In very special cases, we give lower. Very lean PCO who have already hyperstimulated in IUI cycles with, lesser than 75. But otherwise, usually I think if everybody agrees, it's 150.
No, I think we keep 150, agree, Shweta.
And
Yeah.
225. This should be the dose. 300 normally doesn't feature in PCO at all. Maybe later we can if they are showing hypo response. But then the starting dose is not this.
So
Sure,
you
sure.
can give a range of 150 to 225 instead of putting BMI and all those parameters. You can clinician's
That would be
discretion. And again, 300, again, based on clinician's discretion, bearing in mind the risk of OHSS. So you can put it as a disclaimer kind of thing, so it doesn't appear there.
I don't think that in PCO we should give this message to clinicians that you start with 300. Your drugs are not working.
Correct.
That's a different issue.
Correct.
But if
Correct.
your
So
drug is working, I don't think that in hyper-responder we should get the dose of 300 at all.
Correct.
I
Correct.
think we should just say, as we've said, reassess and tailor accordingly, because
Yeah.
rather than putting a figure of, 300 or not, or, committing, because this is something on paper, we want to say, keep it simple, 150 or 225, and tailor accordingly.
Yeah. So that just a range then should be fine, isn't it? Then over there.
Yeah.
Rather
Yeah.
than BMI or AMH or whatever, because that including regular assessments and all those kind of stuff. So that
Yeah.
should be up to the clinician who.
And trigger, we can just write agonist if excessive response, perfect. And HCG if there is normal ovarian response. We can give.
Yeah, you can.
Yeah, of course, of course.
Okay.
Even PGT and ERA, no, we can leave it as per, routine recommendations instead of
As per
writing
routine,
age higher.
I would agree, because I myself don't do, PGTN on everybody who's more than 38. So if you have, let's say, a poor response with only 1 or 2 blasts again, but I think I would agree, let's say PGTN era as per indications.
And don't write day 5 blastocyst form on day 6 also. So we can just say blastocyst transfer. That's it.
Yeah.
Only blastocyst.
Even if it comes on a day 6, it is only calculated as a day 5 for
day
your
5.
transfer.
Yeah.
So that's okay. That's okay.
You can add preferably single blast transfer, preferably.
Single blast transfer.
Yeah.
Should we even mention that pooling and all? Like we can avoid that box, right?
Yes, we can. Pooling in PCOS doesn't make any sense.
Yeah.
So we need not even keep that box.
Yeah.
I think pooling is only for the poor responder
Poor
category.
responder,
You may keep it as an option.
Yeah.
Okay.
And AMH is mandatory. Baseline investigation, we have written AMH.
AFC, AMH, yeah.
AMH is necessary there in PCO? Should we put it as a, if this is a guideline?
I would think so, in today's day and age, if we can.
It will help you
if you're
to
reporting
counsel.
I think we all get it.
It will help you to counsel the patient.
Yeah.
Okay. We will need to do it.
Okay, sir. Thank you very much.
Do it and then get back to us, Bharat. Thank you.
Sure, sir.
Thank you.
Yeah, sir.
Bye.
Thank you. Bye-bye.
Okay, thank you. Bye-bye.
Thank you all. Bye-bye. Good night.
While you're there, one of the last slides, there was no dosing mention of anything. I think just go back to the last slide, please. Last but one or last or something like that. There was no. No. Is it? Yeah.
This polycystic dosing is not mentioned
Is
here.
it the last, which is like a recommendation slide?
No, this is
No.
PCO.
This is the last slide, and I think I will come to this slide later on. Right now, Dr. Kasirappan is talking about this slide. The dose is not mentioned here for polycystic ovarian syndrome. This is the group of
Here
ovaries plus HMG group.
Correct. Here we said we start with a dose of 150. If there is no response, reassess and then go on increasing as per the need.
So that is another thing which can be added on there as
No,
well.
in the last slide. Can we go to the last slide?
No, in
the one
this
after
slide,
this one.
even antagonist on day 6 will be late in a PCO. So that also antagonist based on their discussion the way, because sometimes we have to start on day 4 also. Day 4, day 5 in
Depending on
PCOS.
flexi protocol or fixed, how we are playing, isn't it?
Yeah, maybe we can just put it as a flexible protocol.
Flexible antagonist.
Flexible antagonist. Yeah.
So should we mention here flexible antagonist?
Yes, put flexible.
Yes.
So flexible antagonist protocol is fine. Instead of just start with instead of specifically mentioning antagonist on day 6, we can keep it as flexible protocol.
And again, here recommendation where we say PGTA era, recommended for all patients, but we are very categorically saying no era. I think let's just make it as per indications, because there are few patients where we are doing era as well.
Correct. Yeah, we cannot say, and sometimes patients are also
because we can't say
extremely well
recommend
informed,
one.
and if there is somebody who wants
and then
it, you
say
may
no
have to do
era.
it.
So I think it becomes dubious. Just say as per indication sounds better.
Okay,
Yes.
so wherever we have mentioned PGT and ERA, I think so
Yeah.
we will mention this
As
point as per
indicated,
recommendation
yeah, as per
and as per.
recommendations or as indicated, we
Just
can
like
put
we've said
that.
about polymorphism testing, we've said optional. I think the other one also makes more sense as just putting as optional.
Yeah.
In the
Can I just go to the last slide?
Yeah. Now coming to the So this slide is basically not an outcome of our advisory board. This slide is basically for the feedback of all the advisory board member. Like
Right.
if we want to work out a kind of a strategy, suppose we are going to a doctor. Sometimes they are asking us in which group of patient and which gonadotropin we can start. So if suppose you want to put in a generalized category kind of a thing, if any patient comes to you as a first time he's coming to your clinic right now, if patient is below 35, you can start with recombinant FSH. If the patient is above 35, he's coming, even though he's coming for the first time, irrespective of the other parameters, we can start the patient on recombinant human FSH and LH. That is the first thing. Then, before we come to the discussion, then in next what we are talking in the subsequent cycle, again the for above 35 it remains the same. We will add rec FSH and rec LH. However, in patient group less than 35, we already had a hypo response during the first stimulation. So in that those group of patient who are having a poor response, we will start with rec FSH and LH. However, the patient who are having a normo or a high responder category, even if they are coming on a subsequent cycle, we can continue them with recombinant human FSH. So we wanted to have an opinion of the all the advisory board members, how they feel this as a strategy, as a company we want to go and start discussing with the doctor. So what will be your
I
opinion
still
on
feel
this?
in the first slide where you've said, because there are certain cases of donors where I myself will just give an HMG. So where you've said in the first cycle where we've just put rec FSH for everybody, whether poor, normal, or high.
Okay.
I don't know how everybody else feels, because there could be someone where you would, with first cycle high responder, where, especially with the donor category, we don't want the take home to be everybody needs a rec FSH only.
Yeah, I think that's a fair enough comment as well, because someone might need a little tinge of LH also, isn't it? So
Yeah.
you straight away draw the line and say only a recombinant human FSH.
But I thought they were referring to the first time IVF where they have not had any previous exposure. Like, of course, you'll come to know about the requirement of LH if there is some previous history of
No, Dr. Bharat, what I
hyperresponse.
want to understand is this is not going to be part of a guideline
No.
coming from us, right?
This is not for a guidelines.
Company strategy. So company strategy, I think we just need to look at whether the advice is correct.
So this is not going to be coming
Because
into
they would not
our
want to write
this
HMG.
thing.
Yeah.
We just wanted to know the opinion because all the experts are there in this advisory board. So that's the reason we just want to know what is your opinion, because if we are thinking of coming up with this strategy, because doctor sometimes asks us in which group should I write, in which group should I not write. So and what is happening is that sometimes it has been seen that doctors are keeping rec FSH and LH as a reserve product. If they are failing with all the other products, then they are trying this drug in those group of patient, and in that time what is happening is that they are losing the precious time of their stimulation. So that is the reason, if any patient is coming above 35 years, so whether the doctor can directly give the benefit of recombinant, or I won't use the word recombinant, LH benefit can be given to the patient, thereby we don't lose the time for again the patient failed in that cycle and again the patient coming to the next cycle. So that was the opinion, and we just wanted to understand how you are taking this. If we come up with this strategy that any patient who is coming above 35, we can use FSH LH combination, and any patient coming less than 35 for the first time, here we are not talking about donor right now, we are talking about the patient who is coming for IVF stimulation. So if the patient is
Even
coming
Bharat, someone who's coming for the first time, there are a certain subgroup of patients where I will do a pure HMG or a pure LH cycle. It doesn't always have to be a rec FSH. So I would agree with your age group of more than 35. But even if there's someone who's not a donor, someone who is a young girl, even if she's come for egg freezing, we get young girls. I would not necessarily make a mandate that it has to be rec FSH only. We may prefer it. What you can put it as a preference, but rather than saying as a blanket.
we can use a FSH or slash HMG. Anything can
You
be
can
used.
put Rec FSH preferred. However,
Hmm.
you can put, because if we say only Rec FSH, I think each of us has had patients who you can use either.
Yeah.
Tanya, I think you have to think from a medical representative's perspective. He is going and telling the doctor, so he will only tell
Yeah.
what he has.
So because this is our company perspective, we are talking, madam. Right?
Yeah.
I'm thinking
That's
patient
just for a company
perspective.
perspective. So I
Yes,
think you can just,
exactly.
This
Yeah,
is
this
can
is
go ahead
fine.
with
fine.
whatever you put
This is
across.
fine.
Yeah.
That's
This
fine
is
then.
fine. This is fine.
Fine.
Yeah.
Okay, I think so. Thank you very much for your opinion. I think so that really help us also when we are thinking about our company strategy. And I will again thank to all the participants for doing a brainstorming and coming up because this to put all this thing was really challenging part. But I think so everyone come together have come to the point where we are at least come around 90% a common kind of an algorithm, which now we will be in a position to go and have a discussion with the doctor who will like to use and give the benefit of this Rec FSH LH into their patients. So now,
absolutely.
So what I will be doing
Dr. Bharat.
this. Yeah.
Dr. Bharat. One in group 3 strategy, I have seen the combination of pargovirus as well as HMG. Could not understand what is the logic because pargovirus is like HMG only, no?
Correct. The logic was only to save the cost.
Yeah.
Yes. That.
Nothing else.
No, I remember that. You did say that day.
Yeah.
Yes.
And I think that's why we've said add it only in the last 2-3 days.
Correct.
So that there you've initially got all the benefit of the response and the growth. And, it goes on autopilot by itself. Just to save cost, last 2 days you add the HMG. Or
Yeah,
3
mostly
days.
we are
Then
changing
it's okay.
to HMG only when the follicle sizes have exceeded 15.5 or up
Yeah.
to 16.
Mhm.
Just
You're
to give it to the
confident
last
of
2,
the
3 days.
response.
Yes.
Yeah.
Okay. Thank you. I think so.
Thank you.
That's it. Okay, madam. So regarding this only PCOS group, there are quite a few points we will be working on this thing, and then we will just send for your approval so that once we are aligned, then we will start working on a final algorithm.
And on the wherever there's PGT and error, just put it together as optional as per the
as
indications.
indicated.
Yeah, as
As
indicated.
per the indication. Yeah.
Yeah.
Sure.
Thank you.
Okay.
It's a wonderful,
Thank you.
concise.
Yeah, you guys have done a great job, Dr.
Yeah,
Bharat.
great.
Your team actually, it's like it wasn't easy and it was very impressive actually. That's what I said even earlier when I had a look at it, because it's not easy to compile such a volume together in just one little algorithm. So hats off to you guys.
Yeah.
Hard work.
Thank
And
you.
very nicely covered all controversial areas as well. There
Absolutely.
are people, including myself, who adds in pergovirus with the others, and we do not want to speak about it because you think that you'll be called out upon it. So it's good to have every combination that we're using, and these are things which we ourselves have done and used. So it gives more value to something which is clinically applicable by experts who are using it.
Sure. Yes, madam. Yeah.
Thank you.
Okay.
Thank you.
Thank you very
Bye-bye.
much. Thanks for your time also. It's quite late, and thank you very much. Thanks.
Thank you.
Yeah.
Thank you.
Bye-bye.
Have a nice
Okay,
evening.
good night. Bye-bye.
Good night. Bye bye.
Bye. Thank you.
Thank you.